Afternoon, ladies and gentlemen. My name is Dr. Bob Angell. My background is in, believe it or not, banking, retail, and finance, and also medicine. And my background in medicine, I am a global expert in endocrinology, specifically with regard to type 2 diabetes mellitus. I run 3 global companies, one in healthcare, 2 actually in the cryptocurrency space, and then I'm also involved in defense contract work here for a small firm, Cognitech Corporation, in Salt Lake City, Utah. I happen to reside in Salt Lake City, and I also hold over 75 patents in the area of AI. So I come to you with a few credentials, and hopefully my experience and also my research can help understand how digital twins are used in medicine. In medicine, medical solutions are not easy. For example, you have 2 scenarios. You have surgeon A. They perform the surgery 3 times a month. They have a 1% mortality rate, meaning 1 out of every 100 patients pass on. They have a higher adverse event, post-operative infections and so on. And that surgeon will be available in 8 weeks. Surgeon B, they do the same surgery 5 times a week. 9 out of 100 patients pass away. They have lower adverse events post-op, and they're available in 3 days. You have chronic pain that's almost a 9 out of 10, and those are your 2 options. What are your choices? Well, let's continue. Digital twins can be used in healthcare delivery. They can use digital twins to help patients receiving healthcare services. As we have learned through this conference, a digital twin is actually a virtual environment, much different than a simulation. A digital twin can run any number of useful simulations in order to study multiple processes. Dynamic Bayesian networks can be used and can take a patient's past and present data to simulate what may happen in the future during a visit with their physician, therefore providing a powerful digital twin in the absence of experts. And I'll tell you why that's important here in a minute. Why digital twins using to model type 2 diabetes? First of all, the prevalence is extremely high. There's 12 million seniors here in the U.S. that are diagnosed or undiagnosed type 2 diabetes. There are new cases 1 every 21 seconds. The number of deaths, it's the 7th leading cause of death in the U.S. in 2015, and that number has increased in just the last, just when I checked the last set of numbers. There's a shortage of endocrinologists. It's a major disease, and endocrinologists are becoming more difficult to find and treat diabetes. There's another problem, is there's iatrogenesis associated with non-specialist treating diabetes. And iatrogenesis means that the physicians are actually inflicting more harm than they are doing good for the patient. Hence, digital twins are actually very good to help guide non-specialists in treating diabetes. And then the drug treatment regimen for diabetes, typically the physicians treat with metformin as a monotherapy, but as the disease progresses it gets more and more difficult to go ahead and treat diabetes. And that right there is an eye chart for those, trying to figure out what it is. But all of those are medications that can be used to combat and to mitigate diabetes. So in order to create a digital twin in medicine, this is a very large clinical data problem. So what I did is I took Intermountain Healthcare as a healthcare organization here in the Utah area, and I went ahead and to essentially try to model and create digital twins. I took patients from January of 2002 to December 31st of 2014. My average clinical encounter was 8 out of about 15 of those years, which roughly translated to 300 minimum factors per patient, 1,000 plus maximum clinical factors, with about 500 average. But I had to manipulate over 200 million factors to put the data into a format that could be used for this process. So basically, it was a big data problem, specifically volume, variety, verification of value. And the only thing it did not have was the velocity. So this is actually a fairly large problem, very difficult problem from a data science perspective. Temporal medicine and dynamic Bayesian networks provide the opportunity to handle the temporal reasoning in an appropriate manner, the granularity of the disease. There are it's used for medical decision making. First techniques were started in 1959. And then I proposed to model 6 type 2 diabetes mellitus complications, 3 in the macrovascular area, stroke, MI, and mortality, and then 3 in the microvasculature, neuropathy, retinopathy, and nephropathy. And for those not familiar in medicine, neuropathy is numbness, retinopathy is going blind, and nephropathy is actually kidney disease related to diabetes. So I had to create a data pipeline, which looks like what I have here in front of me. It has to go through a cleansing process. I have to determine what type of granular problem I'm going to solve with the medical problem at hand. I have to align the patient data, which is extremely important. I then have to aggregate some of the factors, and then I have to determine how to fill in the missing data to create a denormalized data infrastructure that can be used for creating digital twins. So granularity, that's defined by disease state. As you can see there, chronic disease, which type 2 diabetes mellitus happens to be modeled in days, months, and years instead of seconds, minutes, and hours with regard to sepsis. I then combined some recent and unique methods. In fact, the temporal alignment we'll talk about in a moment. I had to actually use some data streaming techniques that are used in video. I had to go ahead and aggregate multiple encounters into a single vector. The gentleman there was actually did his research there in Germany. And then I applied some clinical smoothing techniques to fill in the missing data. So patient data can be kind of messy. Those ovals represent the beginning and end of the entire patient encounter during that 15-year period. So in terms of alignment, you either have to model by date and then align everything to that date, or you have to come up with a different mechanism. So what I did is I took each patient encounter and assumed that the beginning and end, I converted to days. And so the number of days that the patients were in the system began that process. And then what I did is I created artificial intervals to represent the granularity. And so I selected either 6-month or yearly intervals and began to create a process to model the patient that way. Those small lines in there represent the number of patient encounters with their clinician in those artificially created intervals. Well, we have to be able to do something with those patient encounters. So you have to come up with a single vector or a single set of encounters that model. So for example, here's what the data may look like. You have in say a year period. And with diabetes, the most important things are understanding what the hemoglobin A1C factor is, and their BMI and a few other clinical factors. But to create a pessimistic clinical model, and that's what you want in this situation, you take all of the most pessimistic values clinically, and you create a single vector, which I have done here. And so that's what happens in this synthetic process. And so these are aggregated encounters for each patient. And then we have missing data, of course. And so you have to figure out that, what was most appropriate to fill that data in. And it turns out that you can use the prior patient's encounter for the previous year to fill in that missing data. And so that's what I use for the process here. And so that is the data transformation and preparation process to actually get to where you can begin to create a digital twin and model the process. And so the dynamic Bayesian network looks like this. You create Bayesian probabilities for each time slice based on those clinical factors, and that's what a simple 10 time slice Bayesian network looks like to predict an MI. So, sometimes it's obvious that you don't need a predictive model for something when you find a porcupine in the patient. So I thought that was kind of fun to throw in there. How do Bayesian probabilities work? Well, let's take a common disease that out of every 1,000 patients, there will be one that has this common disease. And so you look at the relative proportions of that. So 1 out of 1,000 have the disease. And then there's a clinical test that may come along that says, well, maybe we can use this test to further understand whether a patient may or may not have the disease. And so let's say that this clinical test, out of 98% of those clinical tests, actually provide a true positive value. But also, out of those tests, 4.9% of them are false positives, which means they reflect a positive value, and in fact, it should have been negative. The patient was negative. So prior odds are 1 in 1,000. And the likelihood ratio would be 98% to 4.9%. And you would come up with we do the calculation. So look at the posterior odds are 1 out of 50. So you can improve the understanding of if the patient is going to actually get the disease if you could improve those odds with the clinical test. And so basically it's Bayes' rule in statistics, and it's pretty much as presented there on the slide. So I actually created a few tests. I wanted to compare 6-month to yearly intervals to see if modeling 6-month intervals were better than yearly intervals. I wanted to look at some stacked versus regular data methods, because in the literature it stated that it might be better if a patient had one versus the other. And then some studies actually stated that simplifying the models actually worked better than just creating complex models. And there are many other tests that I compared, but but because of time, we won't go into those. So a regular data method would be just take the first 10 years of the patient's data and create a model. But then you have the stacked or a sliding window process, which says take the patient data and create, in this case, you'd be creating actually 5 different, treating each one of those sliding windows as a data, as a vector, and basically by creating 5 more different patients. So that's actually a stacked window model. So to provide results, you have to calculate a C statistic, which is essentially, it tells you what the model performance may or may not be. Basically, you plot the sensitivity versus specificity of your data against one another. And then you also want to calculate a confidence interval to make sure that each one of those processes are appropriate. So here are some results. These are the year intervals that basically provided better predictions for all of the models that I specified: mortality, stroke, MIs, and then for the neuropathy and so on. You can see the C statistics were much higher, and in those cases. The regular data methods, interestingly enough, are preferred and performed a little bit better than the stacked models. So we were able to look at the literature and say, well, maybe that's not the way to go. And then the simple model predictions were much better than the complex models for these models. So to conclude, each one of these models are digital twins that can be inserted in the electronic health record of a given hospital. And so when Mrs. Jones goes in to see her clinician for a checkup or for whatever she's being seen for, the clinician can actually use the past and present data of that patient, of Mrs. Jones, and predict into the future when they may have a potentially neuropathy or retinopathy or nephropathy or any one of the other modalities. And this gives the clinician an opportunity to use this digital twin in a what-if scenario to tell the patient, Mrs. Jones, if you lower this value and if you increase your exercise and lower your BMI and do a few other things, you will alter the probability of getting one of these maladies in the near future. And so the digital twins are actually extremely useful for clinicians, especially when they're not specialists, in helping the patient understand what their outcomes may be if they modify certain things in their lifestyle and so on. So some of the lessons learned: clinical data is extremely dirty and messy and inconsistent, and it required some special techniques I had to do some programming. And so you have to be able to have something that's flexible to handle that process. And then you have to understand the clinical process. So you have to isolate the granularity of the data and develop a process that handles all the disease states. You have to, and data alignment, granularity are extremely important decision elements. And then you have to plan appropriately because you're dealing with vast amounts of data, and you have to basically understand what that problem looks like before you begin, because it's very difficult to make changes once that pipeline is created. But what I've also learned in this process are dynamic Bayesian networks. They've been shown to be effective and a flexible predictive tool for the clinical problem that I presented. And they're also extremely promising digital twins for treating type 2 diabetes. So in a nutshell, I presented about 2 hours of research in a short period of time, and I've glossed over quite a bit, but I hope you get a good flavor for what needs to go in to create a digital twin, and that yes, you can create that process, that model inside a hospital setting and use it to treat patients. Any questions? I'm happy to take questions if you have any.